Hello and welcome to episode 1 of the series. This episode will explore what it means to adopt a family-centered approach to suicide prevention and intervention. So today with our guests, we'll take a look at the complexities and challenges faced by military veteran and public safety families along the continuum of suicide prevention, intervention, and postvention, with the aim to better understand their needs and identify some actionable steps that both communities and systems can take to support them. I will be one of your moderators today. My name is Suzanne Bailey. I'm a social worker by background, and I currently am the development lead for the Canadian Armed Forces Road to Mental Readiness, Mental Health and Resilience Training Program. I'm joined today by my co-moderator, Heidi Cram, who will introduce herself, and then we'll have our panelists introduce themselves.
Thanks, Suzanne. Really excited to be here. I'm a professor in the School of Rehabilitation Therapy at Queen's University, and I'm the research lead for the Families Matter Research Group and project director for the Garnet Families Partnership. I'm also a longtime firefighter spouse. So, why not? Why not do both?
Right. Thanks, Heidi. Laura, did you want to introduce yourself?
Sure, thank you. I'm Dr. Laura Fry. I'm an associate professor in couple and family therapy at the University of Louisville in Kentucky in the United States. And I'm also the program director there of their couple and family therapy program.
All right. Thank you for joining us today. Sarah.
Yeah, hi. Thank you for having me. I am a civilian with Ottawa Police Service for 17 years in different areas. I also work in our wellness section where we help officers and members during pivotal times of crisis. And my position itself was created after the coroner's report on police suicides that happened in Ontario in 2019. I am a spouse of a police officer as well.
All right. Thank you, Sarah. And last but not least, Walter.
Hi, good afternoon, everybody. My name's Walter Bizet-Thiel. I'm a consultant psychiatrist. I'm working in the United Kingdom. I'm a visiting professor at the King's Centre for Military Health Research. I'm a military veteran. I trained as a first general duties doctor and then as a psychiatrist in the military. And after I left, I helped set up national services for veterans' mental health across the UK. Thanks.
Excellent. Thank you.
Okay, so I'm going to start with a question for each of you. So thinking about why is it important that we're talking about suicide prevention through that family lens? And how is that particularly relevant within military, veteran, and public safety communities? So I feel like this is like buzzer beater, like who wants to hit the buzzer and go first? Anybody want to take that to start?
I don't mind taking it if you want.
Great. Go for it, Sarah.
Well, I think the one thing that comes to mind when we're thinking about in the family lens, specifically when it comes to military and PSP, is the fact that it does have there's many systems in place that are at work in the work environment that create more difficulties for family members to know how to navigate when somebody might be struggling or have suicidal ideations. And so the families often are kind of left on the side. Maybe they're told, you have to support this person and this is all these things that you can do to help them. But they also aren't taking into consideration some of the concerns that the PSP and the PSP family member might be thinking about. In particular, in my case, policing, we have a lot of, while mental health has been talked about better now, there's a lot of still stigma around that. There's concerns about losing positions or their job. There's also access to weapons. So there's all these things that I think that are being considered when talking about family and the job itself, what comes with it, in particular with suicide.
Yeah, and I'm to jump onto that, I think suicide is so highly misunderstood, and a lot of that misunderstanding are what families are coming in with of what they're hearing in their community or from other sources. And if we can help kind of combat some of that misunderstanding, if we think about we're tasking families with offering support, we're there on the front lines to see if something is happening and seeing those risk factors. If they're coming in with that misunderstanding, it can just make it harder for folks to seek treatment, to understand where to go, what resources might be available. And it can leave a lot of folks nervous then to seek treatment, of what will happen if I seek treatment. So including the family can be such a great resource to combat a lot of that misunderstanding if we can get the right information into the right people's hands.
Yeah, I mean, I agree with all that. I think the problem as well has been that policymakers forget there's a family in relation to whoever's serving in the military or in the public safety sphere as well. And the policies and safeguards that are put in place usually surround the individual in the workplace. And then, of course, everyone forgets that they have a family. They go home at some point in the day. The other thing as well is the issue I think already mentioned is the stigma of admitting that you have a problem. And I think it's even worse for family members to have the responsibility of maybe telling somebody that my spouse now is having a serious problem with their health. So it is a big problem from that point of view as well. So obviously stigma, mental health issues, losing one's career perhaps, or making my spouse lose his career or her career. If I declare there is a problem, when will I do this? Will it be at the very last minute when people are really kind of desperate, or will it be kind of at the beginning when I notice something is wrong?
Yeah, no, that's great. Thank you, everybody, for your sort of introductory thoughts on that. And I just want to pick up on what something that Laura said with respect to the family, in terms of, from a family perspective or a social work perspective. What does it mean to think about families within the larger systemic context and treatment context, rather than just as a support system or a risk or protective factor?
Absolutely. I think that's an excellent question. Whenever family members are coming in and they're, experiencing a loved one who might be thinking about suicide or having suicidal behavior, they also have their own needs that they're coming into that context with. I mentioned the piece about misunderstanding. They may need some information about what is suicidality, what are risk factors, what to look for, what do those signs mean. They often need more information around what is helpful. A lot of times they're coming in with misunderstanding of how do I help in this moment? Sometimes people think ignoring it is helpful, right? And so there's a lot of needs that they're coming in with of how do we help them provide support. But then they may also have their own mental health concerns as well, of are they coming in already with high levels of stress? And if we put it on their plate to say, hey, I need you to also provide support to your loved one, that can also exacerbate what they're already going through. And anyone who's in a potential support position, there's the risk of burnout and fatigue. And that can happen whenever family members are coming in, perhaps feeling confused about their role, maybe sensing a lack of control, maybe not knowing who they themselves can go to talk about what's happening and how to manage that stress. So family members, to include them as kind of a treatment context in a larger systems perspective, is not just looking at the person who's struggling, it's also looking at those support people to see what unique needs they have. And then also on top of that, the dynamic between the two. What does the communication look like? What existing family dynamics are already there that we need to address and look at, and might also make it more difficult? So it really is expanding. I find it a more hopeful perspective to include the family, because it also gives us so many more possibilities on the table. So to include them in the treatment context it really opens up a lot of options.
Well, definitely. And you get a much broader perspective on the issue.
Absolutely. Mm-hmm.
Yeah. Walter, did you have something to add to that?
Yes, I think this is a great point, actually, the family dynamic. I would add to the dynamic between the family, not the person who's employed, the family and the employer of the person who's employed. Because many times the family is ignored or sidelined by the employer and not included. And certainly when I was in the Royal Air Force, many years ago now, I left 27 years ago, my wife's, everything about my wife was about wife of Flight Lieutenant Walter Teal and my last four in terms of my service number. And she had no name, and she was a qualified psychologist. So the whole thing, the whole dynamic is really important. and for the family member to know where to go for help. So, for example, in the military, we would say, yes, there's primary care, that's general practice, and low-level intervention, perhaps from a medical point of view. Then there's psychiatry or psychology, more specialized. But also we have the padre avenue as well. So padres and people who are non-judgmental in relation to situations whereby maybe the individual's career may not be so much at risk if the kind of red flag is kind of waved at that kind of system. So we need a kind of more neutral system whereby family members don't feel they have to wait the last second to get help. And many of my veterans, so after I left the military, these are veterans in the United Kingdom who've left the military, many of them came for help after their spouse or good woman or daughter or mother gave a final reckoning saying, unless you get help, that's it, the relationship's finished. So if that happens, then of course there's another adjustment the individual needs to make, and that could raise the stakes in terms of suicidality. So the whole thing, the whole structure needs, in my opinion, to be totally joined up. And at the moment, it's better, I think, certainly where I'm coming from, but it's not finished. The job's not finished there.
Yeah, I agree. It sounds like progress has been made, but there's still some improvements or enhancements we can make. So thank you, Walter. And then, Sarah, I wanted to ask, from your particular experience as both a police spouse, but also working in police wellness, what does adopting that family lens to suicide prevention look like in practice? And I think one of the phrases you have used previously is that, families become the first responders to the first responders. So what does that look like from your experience?
I actually really dislike that phrase. So it's not one I use. So just to be very clear, it's actually when I give an example, because people often say it because it's nice and catchy, and it's very problematic in my view. So for me, you hear that. It sounds really great when you're first on, new recruit, the family's like, oh, I'm so excited, and then they're telling you, okay, these things are going to maybe happen, and you might want to look for these signs, and and then all of a sudden you're becoming this person that's no longer spouse, wife, husband. You're now a bit of a caretaker in certain cases. And there's all this pressure to have, all this knowledge around what to look for. And I think going back to your question about how do we involve that family is then really understanding what that role of that family member is, and what it isn't, and understanding also within the systems that they're in, the military or PSP organizations, that the way suicide might present, or suicide ideations or thoughts and mental health issues in the first responder or military personnel is going to maybe look different than in the general public. And in one of my examples I've thought about myself and spoken about is how a lot of the symptoms they say to look for are masked by the job itself. So you kind of are in this world as a spouse or family member, just trying to figure out how to take care of this person. And you end up at the same time feeling like you're failing if you didn't, going back to what Walter said, if you didn't go forward right away, or if you wait till too late. And then of course there's the dynamic where you also, like you mentioned, Lara, is that you have this also going through in your mind that you need to take care of yourself, but you feel almost second class, sort of what Walter was saying. You're not really, you're the person behind the uniform, not in front. Yeah.
So it sounds like there's significant expectations placed on families without necessarily having all of the resources and information that they need. While at the same time, there's sort of this fine line between, what can I do? What can I say within the larger organizational context as a family member? And so, Sarah, where where do you think families feel most supported in this whole, context? And where do they still feel invisible or underrepresented?
So I think there has been a lot of strides in creating more resources and avenues for families to take, for sure. I think the support I think it really depends on each service and in different places. I can speak more to my the police world in that they have considered families at the start often now. So, when recruits start, there's always a family introduction or an event that we and other services have sort of adopted. I think where they're missing marks is being very plain language about what, you then hand all these pamphlets to them about like post-traumatic stress and all these things, OSI injury and mental health and all of these resources, which is really great. But I think it's really important, which has been a huge leap forward, because I don't think that was happening in the past. However, I do think, looking forward, and what I would like to see is the families also being part, sort of, like they say, it's part of the blue family, right? You're all part of the blue family. However, they don't consider you, sort of what Walter was saying, as like equal to. So I would like to say your mental health matters too. And one of the things we have done in our service is when we do have those recruits in our class, and we are talking about, mental health and things to consider when starting in the police service, we also spend a few times during this beginning start of their career talking about how their partners and family members matter too. And really speak to, you're going to have conversations where you're going to sit in the kitchen and they're going to say, oh, I had a really bad day, the partner who's not a PSP or military spouse. And then they're going to go on about, how the printer didn't work and these things that seem so trivial to that first responder military spouse, when it's really not. And that's the tone that starts the whole idea that the spouse then also is not only being told that you're the caregiver, you need to make sure they're okay, but you're also devalued. And that's why it's really important to consider putting these families into that same important framework, because then the PSP spouse takes that moment to go, this is part of, like, this is what we talked about, and that pause, right? So there's just some things I think that need to be communicated more. Yeah.
That's right. And acknowledging that their experiences are just as valid, regardless of whether it's as dangerous or risky as perhaps the day that the member in uniform had, that they're just different.
Right. So Sarah, I'm wondering, when you think about where organizations are in how they see and perceive the role of families around suicide prevention, what do you think organizations might assume families are doing, and how might that differ from what families are doing?
I don't know so that's a good question. I'm not sure that if it's, you ask in particular to suicide, I don't think there is much talk about that in particular. I really don't think so. Mental health maybe, but they're not going into that specific minutia of like the topics in that way. However, I think there is that thought that the family members, they are taking care of that person at home. And it often shows up when there is a member who dies by suicide. The conversation goes, what did the organization do for them? They get mad at the organization often. And then in a more quieter way, how did the family not know? And so that is often the kind of things I've witnessed and sort of heard. And therein lies really, they believe either the organization or just people, and any people, even if it's outside of PSP, that there should have been some kind of signs and you should have done something. And so the expectation really comes back to, well, you were their person and you were there, and maybe he was or she was going to work fine. So the organization maybe didn't quite know, if they're not off, there's that dynamic too. There's people that are off versus people that are functioning at work but not doing well. We don't particularly know, but then they go home and drink a lot and all that. But there are also people that come home and they're just tired and grumpy and not doing well, but they're also just worked a 12-hour shift. They are a little more irritable because they just had a really bad call, but they've had a bad call several times, so where's that line between knowing when to intervene and not? And I think the service or people in general believe that you should know that. And this family members will then do something when it's time. But when you're in it, it's impossible to know.
Yeah, I mean, I think you raised some really great points about what it can look like on the family side, what they see and how they might perceive it. And if they're normalizing some of these things or attributing it to consequences of work, then it might not get picked up. And there are times when it is picked up and people are in treatment and they still go on to die by suicide. And so even when the family does know, sometimes this is how it ends. So the family is left like thinking, but, I thought we were kind of doing all the right things. So there's so many different ways that can look. So I appreciate kind of giving some of that diversity to it.
Yeah.
And so I want to kind of take a step back before we think about what this could look like for meaningful integration of families. Walter, you've got this historical perspective. You've been involved in a lot of these conversations internationally about military mental health. And, when you think about where and when families have been involved in that conversation or get represented in that discourse, what are your thoughts here about where families do or don't fit from an organizational perspective?
Yeah, thanks. Heidi, it's true that I've been involved for a long time. There has been progress. There's no question about that. But certainly a recent policy written here in the UK has done a good job as far as the organisation is concerned, but it hasn't included families, for example. And of course, we haven't defined families thoroughly. We've talked about spouses and kids and all that stuff, maybe, but mum and dad, brothers and sisters, the new girlfriend, the single young soldier in the UK Armed Forces is the highest risk of completed suicide. 4 times, if you like, the rates of their civilian counterparts if they're below the age of 24, and if they've only served a short service commission, usually less than 4 years. So there are kind of areas that need to be looked at. And the other thing, of course, is we don't particularly have high suicide rates in the United Kingdom, but we have clusters of suicide. So regiments that have fought in Afghanistan, that lost a lot of people, had very difficult times. You've got some people still serving in that regiment, and some have left as veterans. But of course, military health and veteran health don't really talk to each other. So if you have one suicide, somebody still serving, then you might have 2 or 3 veterans who know him well, who attempted or maybe complete suicide well. So there are a lot of areas that are really difficult to cover. So my experience is that families, yeah, I think if you're a stable family and there are good connections to the employer, and the employer is such that they are, if you like, aware, the culture is good, they're aware of well-being and mental health. There's also some education within the organization that we don't have bullying, we don't have harassment, we've got mentoring. So it's a welcoming and a supportive institution, and we promote well-being. So all these things are really, really important. And in the past, in my experience, some organizations haven't been very in terms of the atmosphere that certainly young new recruits have joined, and that is kind of something that maybe all organizations need to be aware of and look at on a regular basis. But I do think things have improved. I think nowadays spouses and families do feel more included, but actually the degree of inclusion I think is really, really important, and the, if you like, pathways to actually alert somebody who can do something that there is a problem. I think those pathways need to be clearer, but there has been improvements, all I can say.
So I think the ways for families within these occupational communities to alert someone is pretty frightening. So for me as a first responder spouse, the idea of having to call 911, things are going to be pretty far gone by the time I make that call. because of the consequences. So it's not like you're calling your spouse's colleagues to respond to the issue if you're in other work settings, like there's an extra layer there.
Mm-hmm.
So, Sarah, did you have something to add in?
No, I'm just totally agreeing with you in that same idea that it is so different to then call, the police for your spouse. And now everybody knows, there's all this, and it goes back again to saying, where's that? Like, am I calling at the beginning? Probably not. I'm probably waiting to say, is this really happening? Is this actually happening? And then the question goes back to what I was mentioning before in the particular with police and I believe some military too, having their weapons at home. You have this then other question of where, and also when I do that, I'm betraying him possibly. And there is that as well. And that could be the push also that brings the person forward in that area. It's all those things, right? So no, I completely agree. It's much different dynamic.
Mm-hmm. Okay, so Lara, from a social work perspective, from your angle on this, from a research, from a clinical perspective, how does it look when families are meaningfully engaged in suicide prevention? How can it look, or should it look?
Yeah. It can look in a few different ways. I think I was also thinking, as both Walter and Sarah were sharing, there's been some conversation about a family trying to notify an employer, but I also think sometimes things can happen where maybe there's signs in the workplace that the family doesn't realize is happening. And so an employer doesn't feel like they can betray the confidentiality of the individual to then tell family. And I think family then feel in the dark of, I had no idea this was happening. I think one ways to meaningfully engage family is to really encourage the individual. Can we loop that person into the conversation? If we're talking with somebody who's struggling, who in your life is a support person that you would feel comfortable sharing? But if there isn't anyone, why not? As in, why wouldn't you feel comfortable telling this person? If it's a spouse, if it's a parent of an adult child, why wouldn't you feel comfortable telling them? And is there any way that I, as a professional, can be helpful in that? Can I talk with them on your behalf? Can I kind of maybe have that proactive conversation to, if you're worried about something being said or how they would take it, can I give some context or do some psychoed to help explain what's happening or what their role might be? Can I prepare them for a conversation of us all coming together to talk? I think sometimes it can be just, someone says, no, I don't want to include them. And then the conversation ends there. So routinely visiting it, coming back, saying how powerful a role could be, but then also I can be helpful in helping to frame it so that somebody responds in a helpful way. So I think those routine check-ins are one way to do it as a best practice. Even if the person is involved in that first conversation, maybe we include them in safety planning. Maybe somebody does show some signs of risk and we talk about what are some things they could do whenever that risk is really high, or what are the various treatment options. We include family in that conversation. Let's also follow up with them of how well is this going? A safety plan shouldn't just be one and done. Let's revisit it. Let's come back. Let's talk about what's working, what's not working. And I'll say one final piece of, best practice to include with family is really understanding that in a time of crisis, even the best intentioned individuals, and even those of us who have tons of training in responding to suicidal crises, sometimes that panic gets the best of us and we don't respond like we wish we would have, or that we would have wished we did. And so also revisiting that conversation, then let's process what happened. Why did I choose, to notify your employer against your wishes? Or why did I choose to do this? What was going on? I understand that now maybe broke trust. Let's talk about how do we repair that? How do we want to handle this next time? What was I seeing? Why did I feel like that was the best option? But also, what would you like me to do next time? So I think having some of those process conversations, even after a crisis occurs, can be really helpful.
Mm-hmm. So some of the continuity and the connection to keep those conversations, but being able to have conversations is a pretty fundamental tenet here.
Absolutely.
Engaging people in that. And I think, when you think about sometimes the way systems are set up and these barriers that exist across family and employer, and then the person, where the focus is really on the person being okay.
Mm-hmm.
What helps to make those conversations, those connections more likely, more possible?
There's a few different things. I think some of it is understanding the context of why do individuals feel suicidal at all? Where does that come from? For someone who's never felt suicidal, it can really be a challenge to understand or to help it make sense. And so I think giving some context of how did we get here and, what do we know about what contributes to that? But one way to explain that would be even saying, what are the ways that somebody feels that they don't belong or that they feel like a burden? But I think that directly relates then to how somebody responds whenever someone's in a moment of crisis, because that person's response can also then lead them to feel that they're a burden or that they don't belong. So thinking about it as, what is going to help reinforce connection here and help reinforce the idea that as your support person or as a family member, that I care, I want to do what's helpful. You're not a burden in this moment, right? This is a way that we show up in families, is to be there for one another. So I think talking about it in that context and giving an explanation to the context can make a big difference for family members feeling better prepared of how do I show up in this moment.
That's great. And I think it highlights a lot of actionable items that we can, consider going forward. And, we've talked quite a bit about both the implicit and explicit expectations that we place on families and almost responsibilizing families in the whole spectrum of suicide. And I'm just wondering if each of you has any thoughts on what some of the unique complexities might be when the family system is not protective, or when maybe family dynamics themselves are one of the risk factors. And so how do systems respond to these more complex family realities?
One thing we have done, which was sort of going back to what Laura was saying, is we've created not just so you have your next of kin, let's say at work, usually it's a spouse or a parent or sibling. And then we've asked for them to also, once they've been on the job for a little bit, to pick someone, we call it a blue buddy. Sounds kind of funny, but it's a blue buddy. So it's somebody who's at work, not affiliated, not a girlfriend at work, not somebody that is very much in that other caregiving role, but someone you might lean on as a colleague, a friend, that you would not, we've been very frank about it, that you would not mind knowing your business if it got to that point. And we, in the wellness section we're in, are the only ones that have that access. So as recruits, we try to encourage the whole service to do this, but as recruits get on, we also just sort of make it not mandatory, but we're like, log on. This is where you put your blue buddy in. And we, give them some time because they may have just met their platoon, and they can change it at any time. All those things we always, and we put reminders out. And one of those things that has eliminated some of the challenges that come with support for people that we don't know how to maybe get a hold of. That's the other thing. There's all these barriers that also play into this, is calling someone they may not pick up. Then are you going to their house? Where's the line between the boundaries and these things, and how much are you doing versus what's appropriate? These are the questions. Often we are like, we'll knock on the door when there's actually we're worried about someone doing bodily harm to themselves or others, and that's pretty far down the road then, right? So having these blue buddies, we can sort of say, I haven't heard from Sarah for a really long time. We've been trying to touch base. I'm making those connections. Have you heard from them? Yeah, we actually had coffee last week, and she's just not interested in having conversations with the organization at this moment. Okay, we will just take that seat and come back to it when we can. So that is one way we've mitigated that. And then I also just want to touch on, there's a lot of services that just don't have wellness sections. They just don't. They might have some peer support program. They may have a couple people doing something, but they're not internal actual positions, which I think is a huge problem. So you're asking the organization to do these things, these touch points, these connections, but there's no one can do it. And you're asking people on the side of their desk getting paid for another job to do another job. And it is really a totally different job, and one that should be prioritized. So that's just what I've thought was you were speaking about that.
Yeah, no, that's great. And I think sort of identifying who's within that circle of trust early on in the career. And like you say, it'll change as they go through different phases in their life, but at least having that person you can check with to say, hey, can you let me know if there's anything I need to be concerned about? And that might address some of what Walter was talking about earlier, about especially younger members who don't necessarily have a partner or a spouse. And so who is in that circle of trust?
Laura, you go first and I'll come second. Yeah, you go first.
Sure, that sounds great. Thank you, Walter. Yeah, I absolutely love the idea of expanding the support system, as Sarah was saying. I think, one item that often comes up in this area sometimes is if, you talk about some of those complex family systems, or if there's complex family dynamics already at play there, if there's a lot of conflict in the family, sometimes those potential support people are there, but they're not the ones that are identified as being in my circle of trust, for example. And so a family member who's not in a circle of trust may feel upset that they're not identified as that, or they should say, I have a right to know that my loved one is struggling. And I think we can also help them to understand, why might you not be listed as the support person? Is there any context where this has come up before and maybe it didn't go well? Could we talk about how to repair maybe what happened there? Maybe repair the trust, or what could we do differently next time to help rebuild trust or improve it moving forward? But I think also, there's times where, in a complex family system, there's also a host of different needs that need to potentially be addressed in professional care. And is there any way to create like a hierarchy of needs? So if there's high conflict in the family, maybe that's not what we're addressing first, even if it is a driver of suicidality or something that's leading somebody to have a mental health crisis. Maybe we put that on the back burner while we get safety taken care of how can we make sure somebody is safe and at least has the skills to enter into some of these conflict situations and learn then more conflict resolution skills or improved communication. And I think also another sense is for family members, how are they able to think about their own emotional regulation when entering into some of these intense situations? So what might support look like for them in those situations as well? So even whenever those folks potentially aren't identified as a support person, I still think there's some movement that we can get to help maybe improve that context, decrease their risk of leading to a suicidal crisis, but also improve the likelihood they could be a support person.
Yeah, and I love what you've described. It acknowledges the fact that suicidality doesn't happen in a vacuum, that there are other things going on. And so you need to sort of triage what's the first thing we need to pay attention to, but also recognize that when in these more complex situations, there are still other things that you can do to help everybody involved in that system. Yeah, thanks. Walter?
Yeah, that's really great. And just to follow on that, just as a aside in relation to single young soldiers, for example, peer support and mentoring is very important. But actually, when we look at clinical services, and I'm speaking as a psychiatrist now, who's run quite a lot of clinical services over a long time, Tom Williams wrote a book about family therapy and treating PTSD in the Vietnam veteran era. And his attitude was, we'll treat the whole family and we'll destigmatize the individual who's come back from Vietnam full of post-traumatic stress symptoms, who's really been ill, and we'll treat the whole family as a whole and reintegrate the family. And his work is really fantastic. And I think, it is probably an expensive option to give family therapy to everybody who presents with severe mental health problems. But actually, we did some of this at Combat Stress when I was medical director. We had a family and a spouse psychoeducation program where we taught a lot about what the symptoms mean that your spouse is suffering from, and actually then how to cope with all of that and how to cope with your own problems. And that perhaps was a step down from family therapy, but for some, family therapy then was necessary. So I think looking at things holistically is really, really important in the early stages right up to the end point where, people usually will end up with me when it's the end point. They've got a mental health problem that's established, and, there are big risks running about. But I do think that the culture of the organization, I think the resources, Sarah said, some organizations don't have the resource. And, if you don't have the resource, you can't think about how your policies, the ideal policies, can actually be written and then implemented.
Yeah, that raises a key issue of the importance of sufficient resources to treat the entire picture, not just suicidality in isolation, because you can't resolve it just on its own. You have to take a look at the larger picture in which it's emerging. And I think that raises a really interesting question that, especially in military and public safety contexts, exposure to suicidality, whether it's, within your own family or within the larger public safety family, doesn't stop at that worker, at that situation. And how does this exposure spill into family life, and how are families affected over time, knowing that this is something that does and may happen within the community that they are a part of?
When you were saying that, Suzanne, I very much feel that way when we've unfortunately had a few suicides of members at work. It is very much a trickle into, of course, the organization. It's into the smaller it moves out, but the families are as much affected as well, and not necessarily always brought into the conversation or have a place to go to find support and have those whatever they're thinking in terms. For myself, if I can just, as a spouse, I always go, what happened? How is this going to happen to me? It goes straight back to thinking, am I going to miss something? What it's like, you're constantly just thinking, how do I prevent this from happening? And and it's quite an emotional feeling, because when I have spoken to some spouses about this, it's always a difficult topic. If I got an opportunity to talk about this, sometimes they really didn't know, or they didn't think that it would get to this place. And so there is that thought, as somebody this happens, where you begin to wonder, like, where do we even start? How do I even know if I'm going to be in this situation? And I think a lot of the time, the other thing that we've touched on as well is the spouse is going through stuff as well. And then they get a kind of awakening of being like, I'm juggling young children, rushing to my own job, dealing with the shift work. I'm blow drying my hair in the basement bathroom so I don't wake him up. We're living somewhat together, somewhat separate. So there's all these thoughts that I think come to mind when a big event, like an event like that happens, and you start to really pick apart what's happening in your own life and how you can, not be in the position that those families members are in, and you're like nitpicking everything at the end. So that's just what came to mind when you were speaking about that.
Yeah, absolutely. And I imagine there's a certain element of always second guessing yourself. Am I going to miss something? And Laura, I think you touched on this when you were talking previously about making sure that we're not just treating the acute situation, and when it's over, we don't just, kind of wash our hands and go, okay, close the case on that one and move on. From your perspective, what are some of the key things we can do to support the family and do that follow-up and make sure that after the acuity is over, they continue to have their needs met?
Yeah, I think, again, I feel like I've said this in a couple different ways, but in remembering to include them in the conversation, whether that's a check-in phone call with them of how is this going, and not just from the standpoint of what are you seeing? Is there any risk, that have you seen cause for concern that would be helpful for me to know? But even about them, right? Like, what is this like for you? How are you getting support during this time? Because suicidality can be so stigmatized, the support person can also feel like they can't talk to anybody about it. So where are they getting support? And even facilitating that conversation of, is there anybody in our circle of trust that is okay for me to talk to about this, right? Can we talk to say like this, just to process what happened, and kind of what that looks like now, and perhaps processing that feeling of unpredictability or lack of control that support folks can feel in that time. And sometimes it is, especially if we hear about, a crisis happening elsewhere, or there's been exposure to other suicidality, it can feel as if it comes from nowhere. And I think a lot of the ways that we help folks understand or feel that they have a bit of control is to remind them about opening up those lines of communication, even when there isn't a crisis happening, right? How can we continue the conversation, whether it's about suicide, whether it's about mental health, whether it's about the stress of anything of what's going on? How can we keep those lines of communication open so that when a crisis does occur, we're already there? It doesn't feel like we have to lay new groundwork. So I think reminding folks about that and then reaching out to them to say, how can we help facilitate that? What does that look like? What are times that it's gone well or times it hasn't gone well? Could we learn from those and do better next time or try something different next time? So I think including them in that conversation and helping to mediate that conversation can be really powerful.
Yeah, I agree. And I think that, as both you and Sarah talked about, whether it's the family that's directly affected or other families from within that environment, creating an environment where it's safe to talk about those things and they know, like, it's acknowledged and they're given permission to talk about it. And having somebody like the position that Sarah is in, who is there to facilitate those discussions from within the organization is key to that.
Absolutely. And I'll say one other piece that came to mind as you said that. I think there's also this pressure of, if we're going to talk about it, we have to get it right the first time. And there's a fear of saying something wrong. I think it's also okay if you have a conversation and the next day you're thinking, I wonder if that came out wrong. It's also okay to come back to it and say, hey, I was thinking back to what we were talking about, and I actually want to rephrase what I said, or I'm worried it came off like this. I think it's okay to understand we may not say it perfectly or do it right, as we hoped the first time. And it's okay, again, to revisit and come back to that. And that can be really powerful as well.
So my dogs are making an appearance, as they often do. Sorry. So no big noise, but they'll probably reappear in the background. So one of the things that strikes me when we think about, we don't always have services that have the perspective that you're describing, Lara, this kind of very family, like how do we actually have these, conversations between members of the family, and how do we broker and facilitate those conversations in services? We don't always have, wellness leads that have a family lens. And I think one of the things that occurs to me listening to the conversation is that, like, we have a lot of assumptions about what families already have in their skill set. And I think that these are not kind of common skills that people have on how to intervene in crisis around suicidality, whether it's acute or, ongoing. This is not something that we can presume families know, have, or practiced in. People are not going to get it right. People don't know what the right thing is, as if there's a singular right thing. And I think that coming at it with the presumption that people shouldn't have the opportunity to know these things and how to do these things well, unless they're very specially trained. So where do we start? How do you move that family lens then onto the ground of service provision when maybe it hasn't been the norm? Like, where do we start with that? Who wants to take that one up?
I don't want to take it up, but I do want to mention also with what you were saying, without making the families that caregiver too much.
Yes.
That's sort of where I think there needs to be that you are going to be having more information and maybe understanding it more. Maybe you're going to create that conversation, but it's not all on you. I think that's where the bigger, where I'm of the family lens, I think, okay, I'll do that assist training and I'll do this thing and I'll do all these things. And then what? What am I doing? Like, am I now? Yeah. So I think you're absolutely right. There has to be that with the caveat, but that's not your job entirely. It's together. Right.
Well, and even if you have the training professionally,
Mm-hmm.
you know, in a family context, it's your family member.
Right. He's annoying.
So it,
right. And so it's not like I'm going and let me put my professional hat on, I'm annoyed with you and I'm allowed to be.
yeah. And you put your professional hat on and it'll be like, well, I'm not your patient.
Right.
So, and that's true. So how do we balance that? Where do we start? So, Lara, any thoughts?
Yeah, I mean, I think we all recognize how big of a question that is. There's obviously not a one answer to fit all. I think, where do we start? Honestly, I think a lot of the training of professionals as they're going into the field, I think we have to remind them about this family context and the complexity of it. And a lot of folks shy away from acknowledging it because it is so complex. Like, it's like, well, I just won't deal with that because it's so much to think about. So I think helping to make sense of it so it doesn't have to feel quite so complex. Yes, there's a lot of factors, but you can be quite strategic in a way that it doesn't have to be so overwhelming. Like whenever I talk about kind of making like a hierarchy of what's happening and what do we need to address first. I think that can be really helpful. I think also perhaps even understanding, kind of normalizing that these are skills that most people don't have, or, where we learn these skills aren't necessarily, it doesn't come natural to us. We either learn it because we somehow had an opportunity to observe it, or we observed it going poorly and realized we want to do different. Or maybe we've happened to get some training, like an assist training or a QPR or something where we've gotten some of those skills. So understanding that, yeah, it doesn't come natural, that it is okay to get it wrong, and then trying to get some of those, direct skills into then people's hands where we can, whether it is doing community outreach, trying to be more proactive of, hey, a lot of people think, well, suicide doesn't apply to me because they don't have anyone currently right now struggling in their life, right? And so just reminding the folks that, the majority of folks have been touched by suicide in some way. And it's helpful if we as a community, not just professionals, but as a community, have some kind of understanding that this is a part of human existence, and it's helpful to understand how to respond. So if we can kind of think of it as we all have a role, and here's some helpful tips if you ever get there, can be really helpful.
Can I come in very briefly on this? Look, my kind of take as well would be there are situations where the family is involved in, if you like, points in the individual's career that have huge risk in terms of suicidality. So, for example, being medically discharged out of the blue, whether a physical health problem or a mental health problem. And of course, this is a big blind spot. This transition is a blind spot from a health perspective because the family may be in turmoil. The main earner may have lost his or her job, their role, the house. If they're on married quarters, for example, in the military, there's a huge family disruption with schools. So this is a huge crisis point and the blind spot for many organizations. So, it does need a policy or two or three. And, in the UK, we have service family charities that would deal with these kind of very difficult areas. So the voluntary sector as well is really important if people can kind of tag into that. And these voluntary charities would help people, families, I'm saying, adjust to coming out of the military suddenly, for example. So there are the ways, if you like, to look at this as well. So, but it's really important the organisations look at the inherent risks of what they are doing. Like I think Sarah mentioned, we've got weapons at home that shouldn't be at home. Why is that weapon missing from the office, as it were? And then, of course, we haven't talked about the spouse or the children feeling suicidal and maybe killing themselves as well. And that, there's an American literature on that. High suicidality if one parent, is deployed to a war zone, and if both parents are in the military and both are deployed, then the juvenile children, the adolescents, have higher suicidal ideation. So I think there's a whole lot of stuff that we're really learning on the job, and we need to kind of help with policymakers to help them to put the right safeguards in place.
Absolutely. And Walter, I think you're highlighting that maybe we'll have a follow-up series, because obviously we can't cover everything in the episodes that we have, but no, you've raised some interesting points about specific points of risk and how we need to sensitize people to when that risk might be a bit higher. But as we wrap up today's conversation, I wanted to ask each of you, what is one key takeaway that you would want our listeners to take away from today's conversation?
I think my perspective is if you're an employer, part of the kind of organization, then you need to be mindful of your policies and your practice and your culture reaching families and including families in many things, well-being at the least, and mental health at the most, in terms of suicide prevention, and even in postvention as well, not only with other family members wanting to do away with themselves perhaps, but also other members of your organization. So I think it's about being looking at the culture and the policies that you have in place.
All right. Thank you, Walter.
I can go next. I think, for me, a lot of times we as professionals kind of forget that family systems and support systems in general, whether that's, parents, a spouse, a romantic partner, a friend, a coworker, any of those support systems, I think we forget how dynamic of a system it can be and that they can be changing. And I say that in a hopeful way, in the sense that, sometimes people will say, well, my parent wouldn't be helpful, or I don't want to tell my wife or my spouse. Remembering that can change, right? It doesn't have to, maybe that is today, and we can continue to work on that. And what would that look like? And how could we get there? So I think just a takeaway that families are dynamic and that they can learn and they can shift and change based on what's needed. And that makes them incredibly resilient. And so that's my big takeaway from our conversation.
Yeah, thanks, Laura. It gives that element of hope.
Absolutely.
And I think for me, it's, we've touched on how I do think it's problematic to speak about families being the first responder. But I think my takeaway from this is also to remind the first responder or the military personnel how they have a role in supporting their spouses, that their dismissiveness is often what happens. Even the fact that you can't enter these buildings, because, if your spouse worked somewhere like in, RBC or like at the bank, you could just walk in and go bring a coffee. There's all these like barriers that I think we need to adjust and make more accessible for families. And even to the point where I think the PSP spouse should advocate for that and to support their family at home that are their support system just as much. So I think what I'm taking away from this is that there needs to be more conversations how this is going to be a flow between the two.
No, I love that sort of broadening the lens that we're using to make sure that family is inside that circle and not sort of outside the front door.
Yeah.
But I want to thank each of you for your fascinating contributions to the discussion today, and to thank our listeners for joining us. We look forward to the next episode, where we will take a look at how families can fit into some of the dominant theories and frameworks that guide suicide prevention and intervention in these occupational sectors. So thank you very much for joining us today, and we look forward to the next episode.
Thanks, everyone.
Thanks.